yourselves, please.
I'm Professor Suzanne Aust. I'm from Lancaster University in the Law School. Nice to meet you.
I'm Dr. Alex Mullock. I'm from University of Manchester, again in the Law School.
Hello, I'm Nancy Preston. I'm a Professor of Supportive and Palliative Care from Lancaster University.
Thank you very much for joining us. We don't usually have advisors at our hearings, but our advisors have agreed to join us today. It will mostly be the panel asking questions, but the advisors may ask one or two supplementaries on areas of the finer detail, which we've just spoken about before. So, Minister, thank you for joining us today. If you could introduce yourself and your team, please.
Okay, Deputy Tom Bennett, Health Minister, and I think if we start at the end.
Sure thing. Afternoon, everyone. So my name is Dr. James Gross. I'm a palliative medicine consultant here in Jersey, and I chair the operational group for assisted dying, as well as chairing the End of Life Care Partnership Group.
Okay.
Nice to meet you.
Thank you.
Ruth Johnson, Director of Health Policy for the Government of Jersey.
Anna Hammond, Policy Principal for Government of Jersey.
And I'm Jo Pointer, the Associate Director for Improvement and Innovation, including commissioning.
Thank you. And I believe we're waiting for some nameplates, so they'll be popping in very shortly. So the hearing is being filmed and streamed live, and a recording will be made available. We were hoping to have some attendees today, but I think the weather has put people off, so I'm hoping that there will be some people viewing online. Okay, so we have 2 hours for the hearing. We may stop for a comfort break, but hopefully we'll just be able to carry on and get through the questions that we've got. We do have quite a lot of questions, so if answers could be succinct and focus on kind of new details where possible, please. Minister, some opening questions for you. Can you explain whether consideration has been given to providing greater clarity in the legislation around how unbearable suffering is assessed in order to promote consistency and robustness in patient support?
I think, as I mentioned outside, there's a number of detailed questions here, and the quality of the responses would be much better if I refer those questions directly to either Ruth or to Anna.
Okay, yeah, if you can always try where you can to answer as much as you can, and then
I certainly will, but as I say, there's a colossal amount of detail here, and yeah. So the quality of the response will be better from one of the officers.
So yes, we did give consideration as to whether or not the law should, on the face of the law, we should provide more detail as to what the definition of unbearable suffering was, and also detail as to how unbearable suffering is assessed. It is the case that no other legislation that permits assisted dying, which references unbearable suffering, seeks to define it, and that is because unbearable suffering by its definition is subjective. Our law is very clear about the subjective nature of unbearable suffering. What we have done, because we are very cognizant of the concerns around the subjectivity of unbearable suffering, is in the version of the law that's lodged, we have introduced a new provision that requires assessing doctors by law to challenge the person if the assessing doctor believes that that person's assessment of their likelihood to be able to bear pain or bear the treatment is incorrect. So we have hardwired into the law a check and challenge process. And as you know, there will be detailed assessment guidance, and that assessment guidance will deal with how unbearable suffering is assessed and determined and discussed on a day-to-day basis.
Okay, that's helpful, thank you. My next question was going to be, Minister, you'll be aware of the submission from the Jersey Care Commission,
Indeed, yeah.
And they suggested that clearer guidance should ideally be provided. So am I to understand that that's something that will come after the legislation and will be within the guidance, and that would be covered?
Is that going to be, there's be additional work in
Yes,
in
that will be in the guidance.
Okay, thank you. And also the Jersey Care Commission, they welcomed the proposal to embed the safeguards in primary legislation and noted that this approach helps to ensure any future amendments to the law would require a full legislative process. And Minister, this is the kind of slippery slope argument has been raised, hasn't it, by some critics of the legislation. Could you just explain to us how you have ensured that the draft law is designed to protect against any unintended broadening of the legislation over time?
I think just by virtue of the fact that it's as comprehensive as it is, and any amendments will require the full legal process to be gone through. So I think, as far as I can see, it's as safeguarded as it possibly can be. But I'd invite either of the two ladies to add anything further that they think might.
I think that's okay for
Is
now.
that okay?
Thank you. Yeah, and so you agree that enshrining the safeguards in the primary legislation is an effective way to guard against any incremental expansion. And in terms of future assemblies, and if there were any proposals to expand the criteria or the scope of assisted dying, what mechanisms are in place to ensure that there would be a full public consultation and indeed ministerial oversight, that it couldn't just be kind of easily amended, that there would be full scrutiny and oversight of any future
I can only give you a
changes?
basic answer to that, insofar as we live in a democracy, and I really can't. I can't really account for what any future assembly may or might not choose to do, or the manner in which they may choose to approach things, because as we all know, if there was a move to turn this law on its head from a future assembly, that would be a process that's open to them. So I think there's a limit to what we can do to define what may happen in future assemblies.
Yeah, so we can't, excuse me, we can't compel future assemblies, but in terms of recommendations, and of course we would make some recommendations in our report, but do you feel that it is worth recommending that future assemblies should have that additional detailed in principle debate, which was of course an extra step that you yourself brought for this stage? Do you think that should happen with any future changes?
I mean, we can make that recommendation. I don't know if that's included in anywhere in the draft. Is there any recommendation to that?
So
effect?
it's your opinion that I'm after at the
An
moment.
opinion. To my mind, I think things are sufficiently robust. That would be my own opinion, but
Yeah.
there may be differences of view.
So you think that step is wise?
Well, it can be, yes.
Okay, thank you. During previous debates, and of course we had two, didn't we? Because we had the first in principle debate and then the second, much more detailed in principle debate. There were concerns raised by members and campaigners about the legislation. Could you outline briefly how you have made sure that those concerns have been covered in the legislation and in terms of reassuring people?
Well, I think the process itself, the comprehensive nature of the process speaks for itself. There were a number of concerns raised, and I'm not aware of any specific concern that's been raised that hasn't been attended to.
Okay.
And I think, as I say, that speaks for itself. In my view, if anybody can highlight anything that hasn't been addressed, I'm sure we'd be prepared to address it. But it's my understanding that every major concern, every real concern has been addressed.
Okay, thank you. I'll give one example then. So there were some concerns raised by islanders with disabilities, and the worry there is around coercion or perceived pressure to opt for assisted dying. How are islanders with disabilities protected by this legislation?
I will ask Ruth to provide a bit of detail, but I do remember seeing some of the consultation responses, and there were some disabled people who felt quite annoyed that other people were speaking on their behalf, and that as disabled people, they weren't to be boxed off and told that they're a special case, that they wanted the right to assisted dying if they so wished. So I can understand some of the concerns, but I think we have to respect the rights of disabled people to be treated as individuals rather than be sort of corralled into one, if you like, a batch of people that need someone else to patronise or protect them. So
Yes, I agree with that, but you please do provide detail.
So the law has safeguards hardwired into it, which are there to support and protect all people, including people with disabilities, and those safeguards relate to the fact that the assessing doctors have to be satisfied as to the fact that the wish that is being made is a voluntary wish, i.e. it is not subject to coercion, and that has to be checked at all steps within the process. In addition to that, there's a training requirement for mandatory training, and as set out in the additional information that's been provided in an addendum to the report, a lot of that mandatory training will focus on coercion and identification of coercion. In response to some of the concerns that were raised, we also developed some additional proposals which were adopted by the States Assembly, which was for the creation of multidisciplinary teams. Multidisciplinary teams are really important because they include different professionals with different skill sets, such as social workers, who have a professional experience very often in identifying coercion. So we have hardwired protections and safeguards throughout the whole of the law to protect all people, including those with disabilities. The other thing to say is within the offences of the law, obviously there is offences relating to coercion with very severe penalties, but there are also offences that are in the law which relate to the promotion of assisted dying, and those offences have been built in because we recognise that in some other jurisdictions there has been concerns about the active promotion of assisted dying to certain cohorts of people, including people with disabilities. So we've built in offences to protect against those sorts of behaviours.
Okay, thank you. That's really clear. And we have got some questions that relate to that a bit later on. But I'll move on to the submission from the General Medical Council and the British Medical Association and concerns raised in those submissions. Can you confirm whether whether the law has addressed those concerns? In particular, Minister, the wording around awareness of a person's state of mind and specifically the phrase "as known at the time." Has that been incorporated into the legislation?
My understanding is that there are still negotiations going on to fine-tune those responses, and we discussed this in the briefing session before, so I think you've probably got an update as to where we are on the latest with that.
Yes, so certainly. So obviously we've been, as you would imagine, we've been through those submissions in detail. There are some of the concerns, the submissions that were provided to you were on an earlier draft of the law, not on the draft of the law as lodged. And after we had provided that earlier draft, Anna had active conversations with those regulatory bodies. Those regulatory bodies had raised with us the concerns that they put in the submissions. Yeah. So we have made amendments to the law as drafted, which we believe deal with those. Since the submissions to yourselves have been published, what Anna has done is Anna has gone back to them to say, you have said this is what we have done in the draft law. Are you satisfied and comfortable that we have fully addressed in the draft law the concerns you've raised? And also we have had a discussion with the Minister, and in the event they come back and they say, well, we think that the law would benefit from clarification, the Minister is very open to making any amending clarifications that may be required.
Okay, that's really helpful, thank you. And what would also be helpful to the panel is to perhaps have sight of some of that correspondence if the permission is given by those bodies, so that we can understand their views on it and possibly prevent duplication of correspondence. That would be helpful. Thank you. Our officers will be in touch to arrange that. Okay, I think I have one more before I move on to my Vice Chair. Minister, there is a specific model of assisted dying that you're proposing with the draft legislation. Could you just explain for us the difference between assisted suicide and euthanasia and how that is relevant to the legislation?
I'm not sure that I can completely answer that. The difference between euthanasia and assisted dying, my understanding, and forgive me as a layperson, I thought
assisted suicide and euthanasia.
Yeah.
Assisted suicide.
Happy for officers to.
That's one that I think it's too technical. Yeah. Anna, would you be happy to
So I
attempt
think
that one?
it's fair to say that there's no universally agreed definitions of either. So what our law does is it allows for both of those. So if we're talking about assisted suicide, as in the sense of physician-assisted suicide, that is about a doctor administering practitioner supporting a person to self-administer approved drugs which would end their life.
Yeah.
And if we're talking about euthanasia, under the Jersey draft law, then we are talking about the administering practitioner administering those drugs to end the person's life. So the draft law doesn't use the terminology of euthanasia, but it has that effect, and it covers both as agreed by the P18 proposals, that both sort of modes for an assisted death are permissible, and it'll be for the individual to decide.
Okay, that's really helpful. And the reason we ask is that sometimes in submissions people are using terminology, so I wanted to kind of get to that shared understanding of how
I
it
hadn't
applies
spotted the word euthanasia anywhere in the legislation, so I was slightly confused without having a legal definition of what euthanasia is to actually provide you with a...
but when the panel are reading submissions and background information, that term is often used, so it helps us to establish how it applies to the legislation. And Minister, have you weighed up the ethical distinctions between assisted suicide and euthanasia when you considered the shaping of this legislation?
Not in those clinical terms. No, I haven't. No, well, I've got to answer the questions as I see fit. It's a slightly confusing question for me. I've gone through all of this all the way through the process, and I'm very comfortable with it. So I don't quite know what...
I wonder if the officers recall a
trying to
time
say.
when you considered the ethical implications
Yes.
of the...
Hang on a second. Ethical implications, I think that's an assessment that I make throughout the whole process. The whole thing has to be ethically assessed at every stage, which I'm very, very comfortable to say that I've done. As I say, sometimes the nature of the questions are slightly difficult to answer in the way that you ask them. For me, and perhaps that's because I'm not as...
May I?
Go on,
Yeah.
yes.
I mean, what we're talking about, or what we are suggesting, is that there is a material distinction between a person who takes his or her own life of his or her own volition, and a medical practitioner or a nurse injecting someone to bring life to an end. There's a material distinction between the two. Would you accept that?
Oh, yeah, absolutely, yeah. Articulated in that form, that makes much more sense to me, yeah.
Okay, so if you could just comment on your views on the difference between those two things and...
Well, first, that I do understand that distinction. And secondly, on a personal basis, I suggest that's what you're asking me, that I'm personally comfortable with both.
You're comfortable with both? Okay, can you explain why it was important that you drafted the law in such a way that included both of those?
Well, my understanding from all of the consultation that's been done is that's what's going to be acceptable to everybody. So, but I take it as read that that's already understood.
Okay.
Forgive me if I hadn't quite understood what you're angling at, but the way you articulate it, Deputy Boss, makes perfect sense to me.
I think we're putting to you that there is this material distinction.
There is.
And one of the questions is whether this distinction was discussed with healthcare professionals so as to give them the opportunity of considering whether the law should be restricted, as it would be in the United Kingdom or in England, for example, and in other places, to what is assisted suicide rather than euthanasia.
I fully understand that distinction now, yeah. But as I understand it, the consultation has been endless, and that's been part and parcel of that consultation process.
Yes,
Yeah.
so I wonder if I may be able to help with some specifics. So from the very start of the work that we have been doing on assisted dying, which, as you know, we've been working on for about 5 years now, we were, from a policy perspective, very clear about the differences between euthanasia and assisted suicide. We have built into the public consultations and to the professional consultations we did those distinctions, and we asked people about those two different modes of assisted dying, for want of a better description. We know that there are some healthcare professionals, as there are some members of the public, who support assisted suicide but do not support euthanasia. Our law provides for both of those. Our law recognises those distinctions, and what it very importantly does is it provides safeguards for professionals who support assisted suicide but do not support euthanasia. So administering practitioners, so the people who in our law are there at the point at which the approved drug is provided to the person, can opt to only support self-administration through the person, i.e. to support assisted suicide, or they can agree to support euthanasia. So we have left healthcare professionals, we've left it to the ability of healthcare professionals to determine what their level of participation is. And we have provided them the right in law to conscientiously object to euthanasia and associated employment protections where they do. So we have hardwired that difference of view about the individual healthcare provider's view about the acceptability of those two different modes of assisted dying into our law.
It's not hardwired in the law, is it?
Well, so the law provides that an assisted death can be through self-administration or practitioner administered. So the law allows for that. The law then says the administering practitioner, the individual can determine which of those two modes that they want, and the administrating practitioner can determine which of those two modes they are that they personally will participate in.
That was the point I was making. Is that in the law?
Yes, it is in the law. Yes, it is in the law. Yes, yes.
Professor Ost would like to ask a question.
Yeah, please.
Thank you. My question to the Minister is, was it considered limiting the availability of practitioner-administered assisted dying to those cases where the person, the patient, is physically unable to self-administer the approved drugs?
I don't think that was that considered.
So it was, but it was before you were minister. So it was in the stage of consultation that happened after the first debate, but prior to you becoming cabinet.
But it was part of the consultation process.
Consultation.
And decided that the direction of travel has been decided by the consultation process.
So it's been informed by feedback.
Informed by feedback. That's the most important thing, is we're acting on evidence. It's an evidence-based approach.
Absolutely. And the previous health minister commissioned an ethical review which explored some of these differences, and the previous minister with the previous council of ministers considered the findings of those that ethical review and collectively decided that we should progress developing proposals which provided for both assisted suicide and for euthanasia. And of course, those proposals were laid before the States Assembly, and the States Assembly agreed that legislation should be brought forward that provided for both of those modes of assisted dying. So there has been complete transparency throughout the whole of the process, and it has been a live issue given live consideration throughout the whole of the process.
That's really helpful. Thank you for leading us through that. So,
Follow up one question on that.
yes, go ahead. Yeah.
Would it meet your policy intention, Minister, which is to allow people who wish to bring their lives to an end to do so, to limit the euthanasia aspect of assisted dying to circumstances where the patient or the individual concerned was not able to self-administer? Would that meet your policy aim?
I don't think it would. If everything that we've got in the legislation how it reflects the integrity of a process, then why would I as an individual seek to change that? Bearing in mind, I have to separate my own views from what the general process delivers. And if that's been put out to consultation, the consultation is fed back that that's what the public would like in the legislation, I can't see any reason why I would see fit to intervene or change that process. Is that the question you're asking me? Is it saying, would I see fit to move to change it to be just administered in the case where it has to be?
The question was whether it would meet your policy aim being, as I understand it, to enable people who wish to do so to bring their lives to an end in the circumstances that the law describes. Would it not meet your policy aim if euthanasia, that is to say injection by a medical practitioner or a nurse, were limited to circumstances where the individual was unable to self-administer?
No, I don't think it would, because I don't see why we would be restricting the rights of a person who wants to end their own life to choose the way in which they would like to end their life. And as I say, if the consultation is delivered that that's what the public want, I would certainly want to meet those needs. So the answer to your question would be, I'm afraid, no.
So can I clarify that your reason for keeping that in the legislation is to enable people to have the choice of whether to self-administer or whether to have a practitioner administer? And was that reflected in all of the things that you just mentioned to us? Was that absolutely examined and reflected?
My understanding, that's been part of the discussion, part of the consultation process, and as rightly been suggested, that was part of what the Assembly decided to adopt. So,
and it is permissible in other jurisdictions.
Safeguarding issues arise in the choice that you have made, which would not arise if the alternative were to be adopted. I'm thinking in terms of coercion, for example. If you're self-administering, you're unlikely to have been coerced into doing what you're doing.
I can't really foresee a circumstance in which you get two independent doctors and you'd end up performing euthanasia. I can't envisage it. And anyway, I'll come back to some other comments. But
we do have some questions on coercion where we can dig into this a little bit further. So, Minister, we've mentioned the evidence behind why that has been included in the legislation, and also the safeguards to combat any problems that might arise. You have given us detail of the safeguards that are in there. For example, practitioners being free to say they would like to participate in one or the other or both. Were there any other safeguards that were considered and rejected, or do you feel that you have covered the safeguards as best you can?
I'm personally comfortable. I don't know if you can remind us of any others that were considered. But
So, sorry, can I just clarify? Are you talking about the safeguards relating specifically to a practitioner administered?
Yes.
Yes. Okay. So, so in the policy development work, we did consider a number of options, including the option that Suzanne, the advisor, has just mentioned, which is about saying it is self-administered unless the person doesn't have the ability to self-administer. So we did consider that option. We rejected that option on the basis of consultation with healthcare professionals who expressed concerns around the determination of what did that look like, what did that mean, so we rejected that because we felt that we should not be putting forward a piece of legislation where the professionals had uncertainty as to how they should operate within that legislation, which is the reason why we developed the legislation in the way that we did, which clearly provided for self-administration and administrative practitioner administrative practitioner administration with the associated safeguard of the individual saying this is how I want it, and the practitioner saying yes, I will do that or I won't do that. And in addition to that, not only is there a right to refuse for the administrating practitioner, you may recall that at the point of administration, there has to be an administration witness. That administration witness can also refuse to witness an assisted death, which is a practitioner administered assisted death.
Okay.
Yeah.
Okay. So there weren't any other safeguards for this particular aspect that you considered and rejected?
No more above and beyond the general safeguards relating to what does coercion look like? Is it a settled wish? Is it a voluntary wish? Does the person have the capacity to understand the decision they're making? And that's not just understand the decision relating to having an assisted death, but understand the decision relating to the mode of the assisted death.
Okay, that's really clear. Thank you for that. We may come back to some of these points, but I'm going to ask my Vice Chair to take the next section.
Okay, and firstly, if I could just refer back quickly to an earlier question about the concerns that had been raised by people with disabilities. And you stated that there was a lot of protection against coercion. And I just wanted to ask if that reassurance will be included in the information that comes out about assisted dying.
Yes, absolutely.
Okay. So I've got some questions about palliative and end-of-life care. Minister, can you confirm whether there will be a register of care navigators?
To the best of my knowledge, no.
No?
And I wonder if I might ask for a little clarification. Are you talking about care navigators in relation to assisted dying? So the care navigator is the role within the assisted dying law of the individual, of the professional who supports an individual to navigate the assisted dying process and to make the practical arrangements, such as the referral, making sure that they have an appointment with the assessing doctor. Is that what we are talking about? Or are you talking about professionals who support people who are accessing end-of-life care services? Because those are two different things.
Well, I'm talking about the definition as provided in the draft law, which is care navigator, a non-clinical staff member who will support the individual requesting an assisted death and will support the coordinating doctor. So this, and it goes on, but that's what I'm talking about. So will there be a register?
So as set out in the report to the assisted dying law, care navigators, because they are non-clinical staff, they are employed and engaged by the assisted dying service. They have to go through the mandatory training, but they are not assisted dying practitioners and they are not on the assisted dying register.
Well, so there won't be any register of them?
So the only care navigators that will be employed will be those who are employed by the service. So we anticipate that being maybe 2 people, for example. And if somebody were to act as a care navigator not employed by the service, they would be committing an offence under
So there would actually be no. There's only 2 care navigators.
So whilst they're not on the register because they're not clinical professionals, at any point if someone was to say to the assisted dying service, who are your care navigators, they will be able to say, these are our care navigators.
Okay, because they will be employed by the service.
Yes.
So it's envisaged that access to a care navigator will be through referral by the health professional. So that is how it will work.
No. The law is very clear in that it does not restrict a person self-referring into the assisted dying service. So it may well be that the individual talks to their GP and their GP makes a referral to the assisted dying service on their behalf. But because of the issue of the right to refuse, and for example, their GP may object to assisted dying, so not refer them in, any individual can quite literally pick up the phone and self-refer themselves into the assisted dying service.
So they can self-refer, or they might be
Or they might be
by
referred,
professionals.
yes.
Okay.
Yeah.
So just a bit slightly different. Can patients be fully informed of care options if they have not been spoken to by an end-of-life care expert?
Yes, the law requires the assisted, so it's a requirement on the face of the law for both the assessing doctors undertaking, the coordinating doctor doing the first assessment and the doctor undertaking the second independent assessment. They must by law ensure that the individual has been fully informed of all of their end-of-life care options.
Okay, so that's part of the
Yes, yeah.
Minister, can you confirm whether the proposed end-of-life care law would be implemented before the assisted dying law?
That would be the case, yeah.
Yeah, okay.
Pending Assembly's decision-making.
Yeah, of course.
Take it as read. Yeah.
So, just. Oh yes.
I'll leave it
Nancy?
to you to decide.
Yeah, Nancy, do you want to speak?
Sorry, yes, just back to the point about being fully informed. If the two assessors might be a palliative care doctor or a GP with end-of-life care experience, then that would be very possible to explore all the different end-of-life care options. However, we know in some jurisdictions we have obstetricians, for example, carrying out these assessments who would be less well versed in end-of-life care options. So how would the law account for that?
So the law accounts for that by requiring the assessing doctors to ensure that the individual is fully informed of all of their end-of-life care options. That therefore places an explicit requirement on the assessing doctor to understand what those end-of-care life options are, and the law allows for that to happen by saying that the assessing doctors are under an obligation to seek what we've described in the law as a relevant opinion, so i.e. to seek advice from a healthcare professional with expertise to address any issues or gaps in that assessing doctor's opinion. So the assessing doctor can't say, these are your end of life, this is the limit of your end of life care options. If they do not have the experience to do that, they are required to seek a relevant opinion, which would most likely be from a palliative care expert, in order to make sure the person is fully informed.
I was just thinking about the Jersey Care Commission's submission as well, who suggested it might be stronger if it was enacted within the law that this was a requirement to have a palliative care assessment rather than seek one if someone feels they need one.
So yes, we noted the response from the Jersey Care Commission. The Jersey Care Commission have worked with us through the development of this legislation. It was not an issue that was raised by the Jersey Care Commission with us before. It was new information that was provided via that submission, and we believe that the safeguards in the law and the requirements on the assessing doctor to seek all relevant opinions have the same net effect as a requirement, an explicit requirement to always seek an assessment from a palliative care doctor, which may be duplication of that assessing doctor's expertise.
It does raise the question as to whether it would be ethically correct to enforce that, to force that onto somebody, to say to them, you have to have an assessment, and I wonder about that being an issue, personally. But not something that I'd be comfortable with, I have to say.
So you're not planning to make any amendments?
No, absolutely not. As I say, I think some people could deem that as an affront. I personally wouldn't want that to be imposed upon me. If I say I don't want an assessment, that would be my right. But as I say,
Okay.
that's
And
something that needs to be considered.
I suppose others might consider it as receiving information that might be helpful to them, but I just wanted to ask a question now about the what was the decision to introduce a statutory duty for end-of-life care rather than palliative and end-of-life care?
Was that not down to a decision by the Assembly?
Can I, so in terms of definitions, so we discussed this as a panel, and we understand that palliative means it could be longer term than a year, and end-of-life care is limited to approximately 1 year before
12
that.
months.
Yes.
That's my understanding too.
Yeah.
So yes, please proceed with your answer.
Sorry, could you
So
reframe
what was
the
the rationale behind the decision to limit this duty to end-of-life care rather than a broader duty encompassing both palliative and end-of-life care?
My understanding was that, well, Ruth, you articulate that better than I will, if you will.
So the States Assembly, when they debated it was P18 is the number of it, P18 back in 2024, made a decision. And the decision that they made is that assisted dying should be available for people at end of life, people who are terminally ill. The Assembly rejected the proposal that assisted dying should be available for people who were experiencing suffering but were not terminally ill. People who are experiencing unbearable suffering but are not terminally ill are likely to be people who are users of palliative care services rather than specifically end-of-life care services. So the proposed new duty to provide end-of-life care directly tracks the States Assembly's decision-making on the boundaries of the assisted dying law. So it is appropriate in the sense that it tracks that. There is also another issue, which is that palliative care for people who are not end of life is a healthcare services. It is about the care that they need to be able to live well. There are multiple other treatments, both treatments and care, for which the health minister is responsible, which there is no legal duty for the minister to provide. And it seemed to be odd, unequal, unfair, whichever term you want to use, to provide a legal duty on the minister to provide for palliative care and not to provide for things such as cancer treatment. And so hence the proposed end-of-life care law focuses very specifically on people at end of life because that is what the assisted dying law does.
Okay, so
Wouldn't it be better to put the two words together and to talk about palliative and end-of-life care?
So end-of-life care is palliative care. End-of-life care is palliative care just delivered in the last 12 months of life.
Okay, so what I was just about to say is then in that case, if there were ever to be an extension to the assisted dying law to include people who also had unbearable suffering but not in the last year of life, then there would be a requirement to extend that.
I
to
think it would,
palliative care.
obviously a decision for the Assembly and the Minister at the time, but I think, yes, absolutely,
Okay.
that would need to be the case.
Okay, so Minister, how will the proposed statutory duty to provide end-of-life care ensure equitable access to high-quality services across all care settings, including at home, residential care, in the hospital or hospice, because this must be quite difficult, I expect?
The plans are comprehensive, are they not? Ruth, you're best to sort of run through that as well, I think.
Sorry, could you repeat the question?
So how will this duty play out across all these different settings to provide this equitable access to high quality services?
okay,
You know,
so-
whether it
so-
might be at home. Or,
Okay, so you mean in the event that the Assembly agree that an end-of-life care law should be brought forward. So obviously we've got to develop in consultation with key stakeholders the provisions of the end-of-life care law. But I think that on a kind of very high level, what we would see that law as doing is saying that when a person is in their last 12 months of life, or it's believed that they're in their last 12 months of life, there will be a duty to make sure that on the minister to make sure that that person's end-of-life care needs are assessed and that that person's end-of-life care needs are met. And that will be for all people. And obviously the detail of how those needs are met and where they are met will be subject to consultation. But I think if you look at the work that Joe and James have been leading on in terms of the end-of-life care partnership and the end-of-life care strategy, there is a clear commitment in Jersey to provide end-of-life care to people where people want to receive that end-of-life care. Because one of the things we know is that people at end-of-life almost invariably want to die at home. And that is fundamental and hardwired into the work of that partnership group.
Sorry, did you want to ask a question?
I was just noting the time, and I think we might need to maybe move a little bit quicker through some of our questions.
Did you want to move on to the next section?
I'll leave it to you if you wanted to triage the rest of the questions in your section as best you can.
Okay, well, I just wanted to ask about the monitoring then of the end-of-life care. How will that be done? The performance of how well it's going?
So I wonder if I could hand over to Joe or James, who are doing the work on specifically on end-of-life care.
Shall I start, James, and then
Sure
fill
thing.
in on
Yep.
more of the details? So, for the implementation of the strategy and work there,
Could I just say if you could speak as loudly as
Sorry.
possible, because I think some of the...
Okay. So we currently already publish a quarterly report on the implementation of the strategy, and that's done. In terms of commissioning, we have quarterly meetings with our providers of end-of-life care, and that's wider than just hospice, there's hospice, hospital, different providers of care. In addition to that, we've set up the partnership group that I'll let James talk about, which is even wider than just the commission services, so a much broader monitoring. So we've got detailed monitoring and it sort of spreads out at different levels.
Yeah, I think fundamentally the answer to the question is that's already in existence through those mechanisms that Joe describes in relation to how we're delivering on the end-of-life care strategy. So the feedback mechanism is there and it's formalised and it's reported on regularly. So I'm confident that that mechanism's there and in place and fit for purpose currently.
Okay, thank you. We'll skip some questions if we could send them later in writing. And I just wanted to mention about the Jersey Care Commission's submission to us that has suggested more integration with palliative care when people are seeking an assisted death. So was there anything more that you wanted to say about that, just before I go on?
So I don't think there is, beyond the fact that we are confident that the law requires the assessing doctors to ensure that people have access to the information they need about the end-of-life care options open to them. And also just to say that there is an overarching principle which has governed all of this work around assisted dying, which is clearly set out in all of the reports of the States Assembly, which is that a person who chooses an assisted death is not voting themselves out of end-of-life care. Mm-hmm. End-of-life care is end-of-life care, and some people who are receiving it may choose to have an assisted death. Mm-hmm. It is not the case that the people who are having an assisted death may choose end-of-life care. It is the other way round. Okay. And that is the reason why when we first started to talk about assisted dying, the then Minister for Health and Social Services went to the States Assembly and said, please may we have £3 million more per year for end-of-life care, because that is the guiding principle of this legislation.
Okay, so you would say that it's mandated in law that all palliative care options have been fully explored.
Yes.
Okay, so that's done.
Thank you. Yes.
Can I just into that point? So for me, this is all about choice. When we're talking about the choice of that mode of administration, that's held with the patient. When we're talking about that choice and that awareness of treatment options and palliative care as part of that, that's a patient-held choice. So for me, I just really want to demonstrate that point, that I don't think enforcing as opposed to offering should be the way forward.
I don't want to put you on the spot, but at some stage, perhaps, could you draw my attention to the article in the law which imposes this obligation?
I will do.
On
I will
the-
do. Yes. Yeah. I can't remember it off the top of my head. But
I suspect there'll be a letter.
yeah.
Can we move to talk about the end-of-life care strategy? And are you satisfied that the strategy is developing well?
Personally, from what I've seen, yes.
And I wondered if you could provide an update on the impact of the newly established Living Well team and how it's providing coordination or improving coordination between generalist and specialist palliative care services.
Sure, I'll be glad to take that point. So I think it's acknowledging the difference between a specialist palliative care service being very much a service tailored towards delivering specialist care in relation to physical, psychological, spiritual symptoms a patient may have with a life-limiting illness. And what we recognised very early on within the end-of-life care strategy and its development is we had a large void of care delivery of those patients who weren't imminently dying, or those patients who didn't have very complicated symptom control issues, but still had unmet need. I think a real strength that we've been able to demonstrate from the output of the end-of-life care strategy is the new service of the Living Well team. So this is a team of experienced palliative care nurses, but not to the level of a specialist palliative care nurse or doctor, that would help support a patient with a life-limiting illness and those close to that patient at a far earlier period in their disease trajectory. So patients aren't waiting to develop complicated uncontrolled symptoms or be rapidly deteriorating towards their end of life before being able to access palliative care services. As a result of the end of life care strategy, there's been a huge amount of enhancements of current services and development of new services that means that these patients can access a service before they ever were able to previously.
Right here. Is the 24/7 helpline being widely used?
So it's yes is the bottom line to that. So prior to, so we've always had 24/7 advice line available, but that used to be delivered off island from palliative medicine doctors in Southampton. What we've seen though, in terms of that advice line now being offered through healthcare professionals on island, is the uptake has been exponential. So whereas we may have seen calls through to an off-island advice line measured in a dozen a year, we're now seeing that over a weekend, for example. So I think healthcare professionals who provide the specialist palliative care service day in, day out, based on island, in terms of that familiarity and that confidence that healthcare professionals accessing the advice line have in knowing who they're calling, has been a really positive step in terms of it being utilised far more effectively than the previous model of an advice line provided off island.
Finished with that section. Okay. Thank you for those answers. We have a section now on public awareness, which is something that the panel have been weighing up. Minister, paragraph 10 of the draft law states that the service will provide information and support for all islanders, including online and printed material. Can you clarify what types of information will be made publicly available, and explain to us how this is balanced with Article 50, which sets out an offence to advertise or promote assisted dying?
Okay. If you forgive me, I know you're addressing all of the questions to me, which is fine, but I think I'm just going to pass these require proper answers, and I'm just going to refer them straight to either Ruth, if you can advise me whether you or Anna in that instance would be...
I can rephrase briefly. So basically, we're looking at where the law requires that there's information put out there, but it also says that promoting the service is an offence. So we want to understand, what the balance is there and what types of information will actually be put out there. And I suppose to ensure that no one is prosecuted for providing information that they maybe thought was genuinely kind of okay to do under the law. Is that
perfect sense.
So we had, as you can imagine, quite long conversations with law officers about and law drafting officers about the phrasing of the law. What we wanted to achieve, which we are confident that we have achieved, is to allow people access to factual information about the availability of about the possibility that they may have an assisted death in Jersey. So that is factual information. So under the casting and the drafting of the offence to promote assisted dying, that will not capture, for example, the Jersey Assisted Dying Service producing leaflets that they give to GPs, that when the patient is still sitting in front of the GP can say, here you go, here is some factual information about assisted dying. And that factual information, the intention would be that the assisted dying service will produce leaflets that says, this is information about assisted dying. This is information about end-of-life care. Yeah. So there would always be that constant balance. Yeah. So the offence is cast in such a way as to not capture the giving of factual information. But the offence is cast in such a way that if, for example, a GP, GP is not a good example. If, for example, a doctor was to put a big poster in a consulting room that says, come and talk to me about assisted dying, I'm an assisted dying practitioner, I can support you in terms of promotion. That would be promotion. Yeah. That is not permitted in the law. So those are the differences that we are seeking to achieve. This is a difficult area, and I think that if we are all open and honest, there is a possibility that when assisted dying first starts to be provided, there may be some people who are on the wrong side of that line. So therefore, unintentionally. Yeah. So therefore, they will need to be supported to make sure they stay on the right side of that line.
And will that be part of the training package, that there'll be kind of actual examples like that practitioners will have access to, so that they can determine for themselves, how to stay on the right side of the...
Yes, absolutely. You may recall from the detail in the law that not only is the Minister under an obligation to provide training to assisted dying practitioners, but also to make training available to all health and care professionals, optional training available to all healthcare professionals on the island. And some of the things that will be considered within that training is, what is the law saying about promoting, in inverted commas, assisted dying?
Okay, that's reassuring to hear that. Thank you. We also...
Can I just interject with a
question?
I'm interested to hear what you say about the medical practitioner with a poster on his wall saying about assisted dying, because it doesn't seem to me that the law actually prohibits that state of affairs. What Article 50 says is that a person commits an offence if they promote or advertise assisted dying, A, by intentionally giving information that breaches 78.3a, or with an intention that breaches 78.3b. 78.3b is not relevant, but 78.3a says that a person who promotes or advertises assisted dying or the service may do so only by giving information about the availability of assisted dying and related services, and about where more information on assisted dying can be found. It doesn't seem to me that it actually prohibits what you are hoping is not going to happen.
So can I just...
Yes, go for it.
It's just to point out, you said 78.3b wasn't relevant, but what 78.3b does is it says that they must not do so with the intention of persuading or encouraging anyone to have an assisted death. So I think the example that Ruth gave about come here and I can help you have an assisted death would likely be considered the intention of persuading or encouraging someone to do so.
Yeah, it's it is a tricky one, isn't it? And so kind of on the flip side of that, if practitioners are wary of providing information, is there a risk that some islanders might not actually know that the service exists or have access to the information?
It's a fine balance, isn't it? Hopefully, the balance that's been struck in the law is the right one, because it is clear that you can actually provide information. So hopefully, people would sensibly use that correctly.
That is the risk, which is why it's envisioned that the assisted dying service will produce appropriately crafted information about the assisted dying service.
So you would expect that the service, given that it would produce its own, so leaflets, I'm assuming a website, possibly posters, or
So I think that level of detail is something that we would need to work with individual healthcare providers to talk about what appropriateness of that looks like in the event that the law is adopted.
But the materials would be able to just be sourced from the service.
I think that would be the intention, and obviously not just healthcare providers, but other organisations that support people to access information, such as citizens' advice type organisations or charities that support people.
And there wouldn't be a charge for these materials, would there?
No.
No? Okay.
No.
Okay, and I'm assuming that this will be monitored as the law is embedded. Is that something you're planning to do, Minister, to monitor the awareness of the legislation and access to information, see if any improvements need to be made?
I expect that to be done, but I don't know if it's actually formally documented that we would do that. Is
So-
there
so-
anything that's actually specified?
So on the face of the law, there's nothing specified on the face of the law, but of course it would be good practice. The assurance committee that will be set up will look at matters relating to that. And I think it is the case that if people were concerned about any organisation or any individual potentially overstepping the mark in terms of promoting assisted dying, we would hear about it.
Okay. Thank you. And I've just got one final question on this section, actually, and it relates to islanders with disabilities who may need the information in different formats, and also maybe islanders with additional languages. Minister, will you ensure that that information is available in the broadest possible forms and languages so that it is accessible?
The only reasonable thing to do, absolutely. Yeah.
And just to say, related to that, of course, the law does provide an obligation on assessing doctors to make sure that if people have communication needs, for example, whether English is a special language, or they need signing or whatever that may be, there is an obligation to provide that communication supports needs to people once they are into the assisted dying process.
Okay, thank you.
Okay, I have a question about the training for professionals. So outcome 1 of the action plan commits to continuing the development of the gold standards framework across community and hospital healthcare professionals. Does the Minister consider that adequate funding is in place to support this?
I think there is, but I don't know.
So when you refer to the gold standards framework, just for the benefit of everyone, this is a framework of information sharing that utilises prognosis to make healthcare professionals and those surrounding patients aware of their likely prognosis. So accreditation has been received from the GSF committee in terms of the delivery of that specific piece of education already, and that's being rolled out.
So that's okay. Has provision been made for any ongoing training updates, any updates to this work?
So in relation to the end-of-life care strategy, there's been a significant increase in terms of the delivery of palliative and end-of-life education throughout the island in all different care environments, not just to healthcare professionals, doctors and nurses and allied healthcare professionals, but also non-qualified carers and accessible information and education to those surrounding patients, friends and family. So there's a firm commitment in relation to the ongoing infrastructure to support education across all areas in which patients with life-limiting illnesses in Jersey sit.
Okay, so that seems completely sufficient. Yeah. Okay, thank you.
Okay.
May I ask some questions around safeguards for practitioners? Article 36 of the law sets out the right to refuse to participate, and in relation to an assisted dying practitioner, participation may not be refused and there are no exceptions. What happens if the assisted dying practitioner changes his mind? At what stage? Does he have to give any notice? Can he do it at the last moment?
Change their mind as in
Decide they don't.
You'll have to excuse me. There is buried somewhere in the law, and I can't remember the exact article, but we can reference you through, provide this information afterwards about any assisted dying practitioner's right and ability to step out of an assisted dying process during the course of that process. And can you recall off the top of your head?
Sorry, are you referring exactly to the changing of a practitioner?
Yes.
No, but I can find it pretty quickly.
So the law does provide for practitioners to change, and that can be where an assisted dying practitioner, for any reason, has decided that they no longer want to be involved or should be involved, for example, in the case of conflict, in an assisted death.
And that can be done at any stage?
Yes. And we can provide the pathway through the law that allows for that information on that.
So that's Article 35, is the change of practitioners.
Paragraph 213 of the report refers to operational guidance and training for professionals in exercising their right to refuse. Can you give some indication, please, as to what that guidance will include and whether it will be clear?
Yes, so as well as 213 of the main report, the addendum also gives some more information about the training and guidance. The exact nature of what that looks like is a matter for, if the law is adopted, for the implementation phase in terms of exactly what that will look like. But as we've mentioned before, there's two facets to that. So there's the training that we provided to those who choose to opt in to be an assisted dying practitioner. There is also this training that we made available to all health and care professionals on island, which will step through that option to refuse.
Okay. I think that's it, really.
Okay, I have a follow-up. So we had a submission from the British Medical Association, and I'm not sure if this has subsequently been addressed in the law, but perhaps you could help with that. They raised employment protections, and the example they gave was that a doctor who works 3 days a week as a GP, but is also contracted with the assisted dying service, would not appear to be protected if they applied to be a partner in another practice and were rejected because of
So this was this has been addressed in the version of the law that's lodged, because we now provide, the law not only provides employment protections, but it provides protections for partners. We amended the law very specifically because of that feedback that we received from the professional registration body.
Thank you for clarifying that. I appreciate that. I have some questions around coercion, which is another theme that has come through in the panel and in previous debates and discussions. Minister, the guidance for healthcare professionals, we note that indicators of possible coercion is something that you have said will be included in that guidance for the healthcare professionals. Will there be a clear definition of what coercion is to ensure the consistent understanding of what it actually is? Specifically in the context of assisted dying.
Coercion in all contexts, but also in the context of assisted dying, can be many things, and it can take many forms. So the guidance will not define coercion per se, but what it will do is it provide details as to what coercion may look like, what indicators of coercion may be, and also the relationships or the balances of power in which coercion may occur, and obviously relating to the actual law itself, because there are some direct read acrosses, is it is entirely possible for someone who has requested an assisted death to say to the assessing doctor, I don't want you to talk to any of my family members about this. And we recognise that therefore potentially allows for coercion. What we're very clear about is if the individual says, if, for example, you can't go and talk to my spouse about my request for an assisted dying, that the doctor must inform the person that their inability to talk to family members may mean that the doctor cannot assess the person as eligible for an assisted death, because the assessing doctor must be satisfied that the wish is voluntary, i.e. it is free from coercion, not that they haven't uncovered coercion. So it's a positive requirement to satisfy themselves of this matter.
So it's quite a high bar to actually... clear.
Yeah, just to add to what you're saying, that's one of the reasons why the definition of coercion isn't as essential. What's essential is that the decision is voluntary and that the assessing doctor is sufficiently satisfied of that. So if there are any doubts and they can't be satisfied of that, they can't assess them as being eligible. So they wouldn't meet the bar. Okay, so it has to be really thorough.
Yeah.
Okay, and this is adjacent to this issue, but I noted in the VAUG Task Force report update, obviously coercion is something that was raised in the VAUG report, and I believe that at the time of that update, the training needs analyses had not been undertaken by various agencies, and therefore training around coercion hasn't been initiated. That may not be true for all agencies. But Minister, is there anything that you will do or that you're planning on doing in terms of joint working, given that this is a factor in other areas, in other ministerial departments, to work together?
I haven't got anything planned for that, but Ruthie, as I say, these are points of detail that are best answered by.
So obviously for assisted dying, everyone who works in assisted dying must be trained in coercion. The Minister must provide training, make available training, optional training to all other care providers, which will deal with coercion. But I think that it would be beholden on the Minister to ensure and do everything possible to ensure that there is general uptake of coercion and safeguarding training as provided through VORG.
Thank you. Minister, would you seek to initiate a conversation perhaps with the Home Affairs Minister to identify areas where you could work together, or where perhaps future ministers could work together
Certainly
in that
happy to do that.
respect?
Yeah,
Thank you.
absolutely.
If you could update us on those conversations, we'd be
Okay.
very grateful. And I do have a supplementary, which I will try to word in a way that everyone can understand. I was trying to understand the definition of close relatives that's in the definitions of the legislation, and it applies to, I think, conflicts of interest. And it just brought something to mind in one of the answers there around positions of power and authority. And is there anything in the law that defines somebody who might be in a position of power or authority but isn't a close relative, and how that would interact with the legislation? If that's not clear, we can...
So there is nothing in the law that defines that.
Yeah.
Because I think it is almost undefinable. But obviously within the guidance, there will be, the guidance will be really detailed, and the guidance will look at matters relating to what does imbalance of power in a relationship look like. There is one part of the law that does touch on balance of power in terms of hierarchy, which relates not to the individual person who is having an assisted death, but to the relationship between the coordinating doctor and the independent assessment doctor, which is that the independent assessment doctor is required under the law to disclose any hierarchical relationship with the coordinating doctor, which may call into question their ability to make an independent assessment. So we have acknowledged hierarchical relationships within the relationship between the coordinating doctor and the independent assessment doctor.
That's good to hear, thank you. And of course in Jersey, Minister, I'm sure you agree that like the level of detail in terms of the safeguarding, that is critical, isn't it, on a small island? Thank you. And I know that in other legislation, I think it's the sexual offences legislation, there is some definitions of relationships where there might be power imbalance in terms of coaches and teachers and things. So it is possible to do. And I suppose all I would ask is that, Minister, you would ensure that there is clear direction from yourself to make sure that that is included in the training, which it sounds, yes, sounds like it is. Thank you. Okay. I'm going to move to Deputy Curtis again for a question.
Okay, if I could just refer back to questions that were asked about the right to refuse to participate by a practitioner. I think in the law there's also assertions that the administering practitioner cannot refuse to administer the approved drugs to the individual if the practitioner previously agreed to do so. So does that not confuse the issue about, I think you were saying they have the right to opt out at any time?
So, what the law says is that because the law says that administering practitioners, so we talked earlier about the difference between assisted suicide and euthanasia. So the law allows an administrating practitioner to say, I will not administer the drugs, I will not participate in what some people call euthanasia, but I will support the person to self-administer the drugs. And they have a right to refuse to participate in euthanasia. But obviously, within that right, a person who is generally very sick, very ill, and at end of life, really should be able to anticipate that an administering practitioner won't say, oh yes, I'll do that on Tuesday, and then change their mind on Wednesday. That is inherently unfair on the patient. So what the law says is an administering practitioner can refuse to do that, but not if they've already said that they will do that. And that obviously is based on the individual person's case, not the general principle of it.
Okay, so
Does that make,
yes,
is that
it
clear?
does.
Yeah,
I do
yeah.
understand
Yeah,
your
yeah.
point, but that means that they don't have the right to opt out in all cases.
So-
Do you think that there should be more clarity in the law around that?
So I think it's very much around the
Yeah.
timing and the process
Yeah.
of when this occurs. So the point at which exactly what the assisted death will look like is agreed in the care planning phase. So after they've had approval, but before the death, they decide all of the details about it. So at that point, if you have an administering practitioner, if the individual says, I want it to be administered to me, I don't want to do it myself. If at that point, the administering practitioner says, sorry, that's not what I want to do, they can absolutely opt out. If, to Ruth's example, they say, no, yes, fine, I'll do it, I'll administer it to you. And then the night before they change their mind, that's something that they will have considered. And as Ruth said, in fairness to the individual, will be required to proceed. I mean, the likelihood of a practitioner changing their mind, having agreed to it, is
It's very
extremely
low.
low.
But if that were to happen, the practitioner couldn't be made to do that. So what would happen to them then?
So they would have a duty to do under law. That's where
But they
the
couldn't be
exception
made.
doesn't apply.
They couldn't be made to do it. Though.
But the likelihood is, say if that were to happen, a very unlikely situation, that actually practically the service would probably be able to arrange for an alternative
Yes.
practitioner to do it.
Yeah, yeah.
Yeah. Okay.
Can I just stay on that? So, Minister, do you think that it's appropriate to keep that provision in the law that states the practitioner is still required to administer that service if they change their mind for
It's an
ethical
awkward one,
reasons?
but I think on balance, yes, because I'm just wondering, as this discussion has developed, what would happen if you're bringing in someone else in the place of the person to administer that, who hasn't been through the process themselves, who might want to say, well, you're asking me today at short notice to administer a terminal procedure to somebody, and I've not been involved in this process at all. So, forgive me, there's something that hasn't. You do well to raise this, because I rather fancy there could be a potential problem if somebody pulled out at the last moment and somebody's waiting for that procedure, for the person that comes in and says, well, you're inviting me to do something and I've had no part in this process. And I think that could be a complication. So I think having an obligation on somebody to actually carry it out once they've made the commitment to do so is probably, on balance, the right and proper thing to do in light of the thinking that's just come to mind during the course
Yes,
of
it
this
would be the
conversation.
right thing to do,
Yeah.
but at the same time, somebody might still refuse to administer.
In the event that they do, perhaps we should give some thought to provision for considering what might happen in that scenario. And forgive me, that's something you may have looked at, but have you considered what might happen in the event that somebody, like you say, you can't actually physically make somebody.
No, we can't do. So the assisted dying service, so absolutely fundamental, and this goes back to the point James was making, the whole purpose of the assisted dying service is to provide people with choice at the end of life, and to provide them with compassionate, sensitive care and realisation of their choice. So there is absolutely no way we would want any patient to be forced to have to engage with an assisted dying practitioner who was not willing and happy to support that patient to realise their wishes. And the assisted dying service would obviously work to ensure that that never happens, because everything about this service is about supporting people to realise their wishes, to take control at the end of their life. It is about compassionate healthcare, and we would ensure that the service delivers right and appropriate compassionate healthcare.
But I think, for the best will in the world, you do raise a good point, because, and it's very, very unlikely, and I appreciate that, but in the event that somebody said one day, I'm going to deliver this, and the next day said they weren't, I say, in that very, very unlikely event, I think we should perhaps give some consideration to how we line someone up. The preparatory work we do to make sure that in the event of that, to rightfully deliver what you very well articulated is sensitive and proper care for people, that we do consider a backstop situation as to how we could move in and not make that person have to wait X amount more days when they're expecting a service. So I just think it's something we should give a little bit of consideration to. I don't know if you think that's sensible.
Absolutely.
Yeah.
And there are review processes,
Yeah.
end of life review process hardwired into the review. So that would clearly identify any of those issues. So those issues would be accelerated to the committee in any event.
It may require that you have to have somebody who's also agreed to deliver that type of service to be kept in parallel at the last moment as a standby, so that they've got the background of the situation, so that you've got somebody who can readily step in, so that the patient isn't subjected to any unnecessary.
Yes, so I think this would be a matter for an operational matter for implementation, because the likelihood is you might want that anyway, because then maybe that they're taken ill.
Yeah.
And so that contingency backup, I anticipate, will be part
Your
of that.
administering doctor might get knocked over by a bus. You just don't know. So
service.
it's an eventuality that we need to consider, and I think would something we're happy to do, and probably do that sort of sooner rather than later.
And as we said, the law allows someone else to step in as required.
So the law does allow for that.
It absolutely
You just
does.
need to make the practical provision for that to happen without any interruption or any
And
difficulty for the administering doctor.
because something like this might happen if there's been a waiver of capacity and the family are concerned, and at the as time approaches on the last day or so, there may be all sorts of objections
You might have
raised.
a heart attack.
Might make the practitioner feel very uncomfortable, and I don't know if the GMC would be happy with this obligation on a practitioner that they cannot opt out towards the end.
Personally, I think the obligation should remain. I do, because I think you don't take this sort of thing on lightly, and I don't think it's fair to the patient to have somebody that might just...
Okay.
So the
Might be
GMC
wrong.
haven't raised any direct concerns about this, but as I mentioned earlier, Anna is going through a process of just checking some matters with them, and we can add this to those matters, because the Minister is very clear that if we need to make some minor amendments to the law to address matters like that, we will do so.
Absolutely.
So Anna can add that to her list.
Yeah.
Do you want me to do these now or leave it for now?
I think
At the time.
we follow up, aren't we? Yeah, right. Okay, thank you. So will you update us on those conversations as they proceed? Thank you. And we'll move to...
Can I come to the controversial area of waiver? As a preliminary, ask whether when the survey of healthcare practitioners took place in early 2025, and doctors and nurses were asked whether they would be willing to be an assisted dying or an administering practitioner, were they specifically asked whether or not they would be prepared to act in the event that this waiver of future capacity had taken place?
To answer that. So in terms of the survey participation, they were asked if they'd participate on the assisted dying proposals that were approved in P18, which includes the waiver. There wasn't a specific question on their view on the waiver itself.
It wasn't specifically put to them.
There wasn't a specific question to them.
No. Are you, Minister, confident that there's been sufficient discussion of this waiver of future capacity?
If in the consultation the waiver was actually there and they subscribed to it subject to the waiver, then I personally would be, but you've asked for my opinion on that, and
Right.
that would be my opinion. But
what Article 9 of the draft law provides that the administering practitioner may not continue with the administration of the substance if the individual demonstrates a refusal or resistance to the administration by words, sounds, or gestures, and reflex movements and involuntary movements wouldn't count as gestures. We're into quite a difficult, sensitive area, aren't we, where somebody moves a hand, you don't know whether or not he's indicating a refusal to go along with it or not. I mean, does it not undermine the whole issue of personal autonomy?
You mentioned that we're into very difficult territory. I'll give you an example. I watched my father die of pancreatic cancer, and he had to die of dehydration over a 6-day period. And that was pretty grim. And had my father had the opportunity to opt for assisted dying and he'd signed the waiver, I think he'd have been quite happy to be released from that pretty pitiful situation. So I appreciate we're into difficult territory here, but that's where we are. So on balance, I'm comfortable.
So on balance, you're prepared to take the risk that somebody might die who did not wish to die?
Well, if they've gone through the entire process saying that they wish to die, and they've signed a waiver to the effect that if they become unconscious and they're not likely to come round again, that they wish to have that administered, then I don't think it's humanly possible to go any further down the line of an absolute decision. So you asked me the question, am I personally comfortable with that? I'm afraid I am. And I understand that will offend some people and please some people. And I think we're at the sort of point where that's always going to be thus. We're not going to please everybody, and I do get that.
Well, it does mean, doesn't it, that because numbers of people change their minds at the last moment, it seems, from the experience of other jurisdictions. It's quite a significant percentage of people, I can't remember exactly what it is, 28% or something like that, of people who have gone through the process actually change their minds at the last moment. So those people who have gone through the process and waived the requirement for future capacity might very well find themselves put to death when they actually did not want that to happen.
One has to assume then that they would have changed their mind as they drifted into unconsciousness. Maybe they have, or maybe when they're unconscious they change their mind. I don't know, but I think we're looking at circumstances, I would have thought, where most people who've opted for the waiver slip into unconsciousness because they're on heavy doses of morphine. As I say, I've seen this in my own case, at a point where you don't actually reduce the morphine because that's the sort of state that the person has reached. So I think in practical terms, the likelihood of that happening is very, very, very slim. And if somebody signed a waiver, I think would be in anticipation of the fact that what they would wake up to would be worse than not waking up at all. And I just forward that as you've asked for a personal opinion, and that's all I can offer you, I'm afraid.
Do you think there's a risk that administration being what it is, that doctors will get into the habit of saying to a person at the appropriate stage 6 or step 6, here is a waiver form. Do you want to sign a waiver form in the event that you lose capacity?
I'm not sure that that's the way that a practitioner would go about this. I think what a practitioner would do is make available to them at the beginning of the process all of the information. I think it's probably unlikely that somebody would then go up to someone and say, well, don't forget the waiver, why don't you sign this? I think that would be probably not the correct way for the practitioner to go about the process. So I would envisage a potential patient being given the information and being able to utilise that information, but as we said before, not be actively encouraged to do anything. As I say, so long as it's carried out in the way that it's specified, I don't see this as a risk factor.
Can I ask, so to clarify, what might that look like at that stage in the process where the waiver is being discussed, and the situation that the deputy is describing? Will that be clearly explained to the individual that if they sign this waiver, will the full implications of the signing of the waiver be fully explained? And what might that look or sound
Certainly
like?
envisage that, but perhaps you could give some more detail on what's
I think
prescribed.
there's a number of things that's quite important to understand, is that the person will be asked if they wish to sign a waiver, but signing a waiver in itself does not mean that the assisted death will take place. So during the care planning phase, the person will be asked to sign the waiver and they will also have at that stage to say, I am confirming that I am making my kind of like final request for an assisted death. The administering practitioner must be absolutely satisfied that the person at the point at which they are saying, I am signing this waiver because I am making my request for an assisted death, that they have capacity to make that decision. So they cannot sign a waiver unless they have said, yes, I want to proceed, and yes, I've got the capacity to make this decision. So
they're taking responsibility for that.
They are taking responsibility for that. At the point at which the assisted death is taking place, and it's really important to recognise the time frames in most of these processes. The time frames are days. They're not weeks or months. They're days in most cases. So, but at the time of the assisted death, if the person has signed the waiver, but the doctor, the administering practitioner, is not satisfied as that they wish to proceed. So those gestures that we've spoken about, the administering practitioner can halt the process. They then may, that doesn't mean to say that it's halted forever and a day. They can then return back to the person to establish whether or not it is appropriate to proceed at a different stage. Capacity at the end of life is often fluctuating, and it's fluctuating because of the person's ill health, and it's fluctuating because of the medication that they're on. So we've thought, you know, we've designed a law that allows that administrating practitioner to make in the time decisions about whether or not they believe it's appropriate to proceed. And you were asking whether or not we had consulted and discussed this waiver with healthcare professionals. We have done extensively, including with the working group that James is the chair of, including with the professional leads group. And we've also discussed it with the assisted dying practitioners in other jurisdictions who are current practitioners of assisted dying, who have lived experience of supporting people to have an assisted death. And they are very clear about the importance of providing a waiver at the end of life, because one of the things that they have said to us is there is almost nothing worse than turning up on the day to either administer or support a person to self-administer, and with their family and friends around them to say, I'm really sorry, your loved one had capacity yesterday when they made this decision, but they've lost capacity today as a result of the medication they're on or their drugs, and to not proceed with that assisted death, not only for the person, but for their loved ones around them and the associated trauma. So we have discussed this with healthcare professionals, and we have worked really hard to listen and to understand what they have said. And we've been very clear that about the waiver. It was part of the report and proposition that went to the States Assembly.
A waiver can be withdrawn at any stage, can't it?
Yes. Yeah. Yes. Yeah.
But I mean, the circumstances that you describe are well understood. But at the same time, different circumstances where a person has lost the physical capacity to communicate, but not the mental capacity, and has changed his mind and doesn't want it to go through, he can't stop it.
So they can if they're gestures of refusal.
Well, if he's capable of making a gesture which is understood by the practitioner as being something that indicates dissent, If he can't do that, that's bad luck.
Well, I'd probably just come in, if I may, and pick up your point about the risk that you're identifying, that somebody, in your words, Sir Philip, could be put to death, unable to communicate a decision that their choice had changed in that period. I think from my perspective, there would be a very fair assumption that if somebody had continued to clinically deteriorate to the point in which they couldn't speak and they lose capacity and that capacity doesn't return, that associated with that deteriorating function would be a deteriorating mental function. It would be very unlikely that they would maintain cognitive ability to be making a different decision in the context of their body failing and fading to the degree in which they couldn't verbalise or recognise around them what was happening. So our assumption here is saying that somebody would maintain the cognitive ability to change their mind despite losing capacity and the ability to communicate. And from my perspective, if somebody was deteriorating to the point in which they couldn't talk to me, then there's a very strong assumption that they wouldn't have the cognitive ability to be thinking about such a complicated topic and making a different decision by the default of how poorly they were in losing the capacity that they lacked.
An assumption, but not certainty.
I don't think in healthcare you can be certain and about anything.
In human terms, it's difficult to imagine a scenario where you can't even make the gesture of blinking your eyes, where you would want, I certainly wouldn't want to continue in that situation.
I think to James' point, it's not like, for example, someone having a car accident and being in a coma and having mental
very, very
capacity.
different.
It's different with a terminal illness at the end of life. And so the other thing, just if I may, to pick up on the statistics about people who have an approval for assisted death but don't actually proceed to the assisted death, which is usually around sort of 25 to 30%. That, just to be clear, that includes people who choose to change their mind, but it also includes people who actually died before they get to the stage of having assisted death. It's probably a larger percentage of those people actually just reach their natural end of life before they have the assisted death.
Okay. And they can have changed their mind at any time before the assisted death. It's not necessarily on the day.
Mm-hmm.
Okay.
Well, the difficulty is that there are instances where these kind of circumstances have been recorded, aren't there? There's been, I think it was in Holland or in Belgium, one of those two countries, there was a case where there was a confusion as to whether or not the old lady had indicated a dissent or a refusal. And she was actually put to death, or I shouldn't use that expression perhaps, but she was treated, and there was subsequently a judicial inquiry as to what had happened. I think one of the presentations that I went to explained that in some detail.
The use of terminology is important, and you said, you did correct yourself when you said put to death, but one could also articulate that by saying that her wishes were carried out, and I think that wouldn't be unreasonable. And I just wonder what the outcome of the review was, because it would be very difficult to have ascertained post-mortem of what the intention...
I think I recall from the presentation that the outcome of the review was that the future practice should not be to give the injection when the signs of distress or whatever they were being...
But we
have
here we have any
But
sign
they-
of distress
they should
at
be-
all
yeah.
should be taken as an assumption not to continue. Is that
Well,
not right?
It is,
I think,
it
but
is.
that safeguard I think is already in place here.
Okay.
And in terms of the numbers of people that might be asking for a waiver, are you aware of anything from other jurisdictions that indicates? I think some of the evidence that we have from our advisors indicates that only around 3% of people actually ask for a waiver in territories where it is permitted. Is that something that...
From what we understand, and it can be really difficult to get any kind of real evidence about the details, specific details of assisted dying in another jurisdiction. But from what we understand, it's very, very small numbers.
If it is such small numbers, Minister, that might access this, and given some of the concerns raised, do you feel that that you still want to include this in the legislation?
Absolutely.
Can you explain why it's important, why you feel it's important?
We, in the modern world, we put a lot of emphasis on minorities and minority rights. And this is just another case. It might be a small minority of people, but why would we not listen to them?
Anything further? No? Anything further on that? No. Okay, thank you. I want to ask some questions about the death certificate and identity of the practitioners. Minister, could you help us to understand how or whether the death certificate that is published will keep the identity of the certifying doctor or the assisted dying practitioner confidential, or whether that would be published?
These are more detailed questions. Once again, I'll hand them over to either you or Anna.
So-
There's a distinction between those two. So the certifying doctor is the doctor who completes the medical certificate. So obviously they would be the one signing the certificate. So very much they are the one carrying out that process. In terms of the administering practitioner, who was the one who either supported the person to administer or administer the medication, there wouldn't be any read through into the death certificate to identify an individual doctor in terms of the fact that they administered the medication.
Okay, so would they always be two different people?
Yes, very much so.
Yeah,
That's an
yeah,
important
yeah.
safeguard that the certifying doctor isn't the one carrying out the act.
Okay. So the assisted dying practitioner, that is confidential. That's
Yes,
okay.
the law prohibits anyone putting any information into the public domain about an assisted dying practitioner unless that assisted dying practitioner has consented to that information being put into the public domain.
But that information would go to the post-death review panel,
Yeah.
obviously,
Yeah.
so they can
Yes.
be aware of trends in terms of
Okay.
activities of the
Yeah.
practitioners,
Okay.
their review processes.
Thank you. I think.
I've just got some questions about reviewing and monitoring of the service. Given there is a small number of cases expected, have you considered reviewing all requests for the assisted dying service within the first 3 years of running the service to be reviewed?
So the law provides that where there is, so the law provides for oversight of the assisted dying service in a number of different ways. But one of the things it very particularly does is it says that there must be a review panel, and the review panel must review every single assisted death that takes place. So there's an explicit requirement on them to do that for every a day. To review assisted deaths that took place, to look for any patterns or concerns, whether that's about the sorts of individuals having an assisted death or if that's about the practice of the doctors. The law then also provides that the review panel may review any requests for assisted dying that do not result in an assisted death, whether that's because the individual changes their mind or whether that's because the person dies before the assisted death takes place. So the law allows for either of those things to happen. The law also says that the Assurance Committee and the Minister can place requirements on the review panel to review those assisted dying processes that do not result in an assisted death. But when it comes to ones that result in assisted death forever and a day, not just for 3 years, for eternity, there will be a review of that process.
Okay, so that every assisted dying death is reviewed?
Yeah.
And is it mandated, rather than advised, that also any requests that don't follow up? Is that...
So the law allows for that to happen, but it does not say that has to happen in all cases. So, for example, if a person makes a first formal request for an assisted death and is found not to be resident in Jersey or to be age 16 or whatever it is, then that process stops, and we would not be looking to review those sorts of requests.
Okay.
So I think Anna wanted to...
Yeah.
I was just going to say, whilst that's not
Yeah.
on the face of the law, it's likely, I think, which is what you were suggesting, that in the first couple of years as a service comes up and running, that actually there'll be more review to try and understand things like drawing of requests.
Okay, and will there be an external review, and at what point of the process of the service?
So, an external review of the whole of the law of the assisted dying service.
The assisted dying service, I
Okay,
think.
so the Jersey Care Commission will independently inspect and regulate the assisted dying service. So you've got the Assurance Committee who are responsible and have powers to take action around assisted dying practitioners. You have the review panel who review every single assisted death. And then you have the Jersey Care Commission who will come in and do independent reviews of the assisted dying service. And one of the things that the law does is it makes an amendment to the regulation of care law. So under the regulation of care law as drafted at the moment, the Jersey Care Commission can't deregister a service where the minister is the only provider of that service. Deregistration of a service effectively shuts it down. But we are using the assisted dying law to amend the regulation of care law to say, if the Jersey Care Commission has got concerns about the safety of the assisted dying service, even though the minister is the only provider of that service on the island, they can deregister it, so they can shut it down.
There's a carve out just.
Yes, yeah.
Okay, and will there be any surveys of practice, such as in the Netherlands, so perhaps family members or so on could contribute to a survey?
So the law doesn't specifically mandate the fact that there are surveys of family members, but I have got absolutely no doubt that the Assurance Committee, which has to assure itself of the safety and the quality of the service, will be looking to speak to family members and loved ones about the process.
To get the feedback?
Yeah, absolutely, yeah.
Okay, and who will provide advocacy services?
Okay, so assuming the States Assembly adopt the law in January, there will be an 18-month implementation phase, and during that implementation phase, we will be developing some regulations that sit under the law. And one of the regulations will provide for detail about the advocacy that will be provided to people who've requested an assisted dying. So who gets advocacy, what sort of advocacy do they get, what are the standards, and what's the training and requirement of the advocate who's providing that advocacy. So a little bit like under the mental health and capacity law, there's specific regulations that relate to advocacy. There will be under this law as well. So that detail's got to be worked out, but the law requires the minister to bring forward regulations that provide all those details.
Okay, thank you.
Okay, we have 4 minutes and I think 3 remaining questions.
Right. Minister, one curious thing in the law, which perhaps you could elucidate for us. Article 77 says, the minister must make every effort to establish and maintain an assisted dying service. And we've found the words make every effort too rather curious. I mean, why not must establish?
I'm not familiar as to why those particular words were chosen, and if you can help me, Ruth, I'm not familiar with why those particular words were selected.
The reason why those words are in there is there are circumstances in which the minister may not be able to provide an assisted dying service. So if the minister is not able to recruit and identify a sufficient number of practitioners, people who choose to be an assisted dying practitioner, to safely deliver the service, despite the minister's best endeavours to do so, the minister cannot stand up that service because that service must be safe. So that is the reason why there's that rather strange wording. So there's a requirement on the minister to make every effort to do it, but we have recognised that there may be some circumstances beyond any minister's control in terms of their ability to actually realise that.
Okay. Final question, again, slightly legal question perhaps, but the draft law provides that suicide is not an offence, which is fairly obvious, I would have thought. But it does say that there is an offence of aiding, abetting, counselling or procuring a person's suicide. Do you envisage any difficulty with that provision in relation to a person who assists somebody to take his own life under this law?
It's got to be very dependent on the circumstances that relate to that, because if assisted dying is
Not suicide.
is legal, then it becomes quite difficult, doesn't it? Just becomes a legal test, does it not? Right?
So what the law sets out is that assisted dying is not suicide.
And that's the reason for thinking that there is a clear distinction between assisting somebody to commit suicide and assisting somebody to have an assisted death.
There's a number of reasons why the policy principle of assisted dying not being labelled as suicide went into the law, which was formed part of the consultation process. But ultimately, the effect of that is that the law is explicit in that assisted dying is not considered a suicide, whereas there will be the creation of an offence that assisting someone's suicide exists. But that wouldn't impinge on anything that is done within the scope of this law.
Okay. Thank you. Do you have anything final? Okay. Anything to add? No? Okay. Thank you very, very much for the answers to the questions today, and I just wanted to note the weightiness of the topic that we've discussed today, and for anybody who may be watching online, if anybody has found it difficult, the listening lounge is available on 866793, and also just to thank you, Minister, and officers, everybody present, for the work that is going into this. And it's very clear to me that the weightiness of this topic is being taken very seriously, and the hard work that's gone into this is considerable, which was clear from the detail in the answer. So thank you for that. We will have a few questions that we'd like to follow up in writing, so we will get those to you as quickly as possible. Right. And to also thank our advisors. Professor Preston had to leave to chair another meeting, but I will send my thanks to her, and thank you to the advisors for joining us today and for the questions that you gave. Do you want to add any final
if I could
comments,
reciprocate
Minister?
by thanking you for the in-depth nature of the questions, the quality of the approach to this. Very much thank the team here, because, as I say, and apologise to anybody listening if they're looking at me thinking, why haven't I got all the answers? I think you can see these good people have been working at this for a very long period of time. I've got all the technical answers that are required, and from my point of view, it's just impossible to have that depth of knowledge. So if I can apologise to people if they think I'm not doing my homework, I have just so much homework to do, it'd be impossible. So anyway, thank you.